Welcome to St. Luke's Care CME. My name is Brent Beasley. I'm the Medical Director for St. Luke's Care. Today I have two gentlemen joining us. We have Dr. Hasib Ahmed. He's one of the hospitalists in the St. Luke's Health System, and Dr. Russell Davis, who's one of our cardiovascular surgeons. Today we're talking about blood utilization management protocols and order sets. We'd like to tell you a little bit about what's going on in the St. Luke's Health System, as well as what some of the recent literature shows about blood transfusions and blood utilization management. So gentlemen, welcome today. And let's just start off, Hasib, if you don't mind kind of giving me a little bit of why you got interested in blood utilization management to begin with.
I got interested in blood utilization really when I came to St. Luke's Hospital, to be honest. I trained at KU, and over there we weren't really using much of the blood conservation strategies. And then as more research came up, and we learned a lot about the side effects of packed red blood cells and FFPs and things like that, started to raise more awareness. And that's when I kind of went back and started to read the literature and then really began to understand it, and then started to develop a passion for it. And then I started meeting people like Dr. Russell Davis and other folks here at St. Luke's, to be honest, and kind of went from there.
Great. Russell, you want to tell us a little bit about how you got involved?
Well, actually, mine all started when I was a fellow here. I was a fellow in heart surgery here back in 2001 through 2003. And at that time, we were acutely aware in our program about it, and we had a fairly active blood conservation program here. Somewhere along the way, it kind of dialed back, but when I went to Arkansas to train, I initiated some blood conservation programs and noted some increased or better outcomes from my patients. And so I started getting more and more passionate about, to use your word, passionate about what exactly is impacting my patients. It was a selfish thing initially because I wanted my patients to do better, But as you started delving into the research a little bit, you started saying, well, there's actually reason behind this madness, and I developed some blood conservation committees in Arkansas. When I came back here, we had kind of stalled on our process as far as blood conservation, and I was a little disappointed as to where we'd gone. We'd actually gone backwards since I was a fellow, particularly in the heart surgery program, and so I starting to push it from again a selfish standpoint. I wanted our outcomes to be better, and so we've just kind of it's evolved from there, and it's all the more interesting each time you learn a new process. It just becomes more interesting that it's many transfusions or many transplants that we're giving these patients and no one's aware of it, and I think it's an opportunity for us to make a big impact in the community.
Kind of interesting you say a mini transplant, and I heard someone else say mini transplant, except you're not using any immunosuppressants for that transplant. Right. So you're having the whole body's immunologic response.
Absolutely.
What we're going to look at now is a little bit about the literature, the recent literature. As a general internist, some of the studies that have cropped up over the last 5 years or so really surprised me. When I went through training, we always believed that giving a transfusion made the patient better, that they were going to get well faster. And the recent literature is showing that that's not true. I think it's also valuable that we have both a medicine doctor and a surgery doctor here from both sides of the aisle, so to speak. And who more critical than a cardiovascular surgeon dealing with hearts and to really help us put perspective on this literature. So as we walk through this, I'd really like to hear you guys' perspective on what you're thinking when you see these studies. The first one we're going to start with is a study that was in 2009, anesthesia, and the association of perioperative red blood cell transfusion and decreased long-term survival after cardiac surgery. So we see here this was a prospective study looking at the exposure to either 1 or 2 units of red blood cells was associated with a 16% decrease in survival. We see this early phase from surgery to 6 months. Down at the bottom on the x-axis we got 0 to 6 months, and on the y-axis we got the proportion of patients surviving. And the black line we see is no red blood cell transfusions. versus those who had 1 or 2 units of red blood cells in the red line. Gentlemen, any comments about this?
I think it's interesting from our standpoint. Again, to try to involve my previous partners in Arkansas, I started kind of throwing this data out at them, right? And they're an older group of guys, and they're like, ups, and they poo-pooed it. So we had data that we looked back from for the previous year, and we took all the other variables out except for blood cell transfusion, and there was a 5% versus 2% mortality rate in the early phase. All right, I think it's interesting that this study is actually showing not just in hospital mortality. I mean, it's got a long lasting effect, and I think that it's hard for me to show that to these guys, but I think that it starts from the time you transfuse the patient, and it persists.
Right, and you're exactly right. When you kind of start off talking about how do we improve patient outcomes, and this study really clearly shows the adverse effects that red blood cell transfusions have on these patients in terms of survival. So we're actually seeing poorer outcomes in these patients, and so studies like this kind of make you stand back and kind of question before you transfuse that 1 unit. Are we treating just a number, or are we truly treating somebody who is symptomatic and anemic, and is there a real indication for why we're transfusing these patients?
Let's go on to our next slide. This one's study, the Journal American College of Surgery in 2009, intraoperative transfusion and general surgery. So now we've gone to just general patients. This was 125,000 patients. This was in the NSQIP database, and the NSQIP database is a national database of surgery patients. Looking at this risk, increased risk they found with 1 unit versus 2 units. So not only is there an increased risk, but it's dose dependent. So the 30-day mortality, 32% versus 38%. Surgical site infection, 23% versus 40%. Pneumonia, 24% versus 25% higher. Sepsis, 20% versus 53% higher. And they concluded in this study that transfusion of mildly hypovolemic or anemic patients should be discouraged in light of these risks.
Yeah, I mean, exactly. I mean, so we talked about overall survival, decrease in survival rates. Now we're also seeing pneumonia, sepsis, surgical site infections as markers of poor outcomes. And so again, this is just one of many studies that have really come out and started talking about the increased risk of just not only 2 units of blood, which, I was trained that way, everybody got 2 units regardless. Now we're also seeing, even with 1 unit, you're seeing a lot of adverse outcomes.
No, I agree. That's exactly the way I trained. If they're sick enough for 1 unit, don't waste it, give
Right.
2, right? I mean, that's the way we always were trained. And I think that's an important note, especially since we train young people here. I mean, the point is give blood when it's needed, when it's necessary for treatment, but don't overdose. You can overdose. I mean, there's clear data that shows it's truly dose dependent, and we have an opportunity. It's a lot easier to say, I give 2 units and give 40 electrics in between and hang up the phone, and you won't hear from them the rest of the night, but you'll keep that patient days longer. You'll have problems post-operatively, and I think that that's the important point from all of this.
Yeah, so exactly. Increased length of stay, and also the cost. So the healthcare dollars that are being spent on treating the increased length of stay and these adverse reactions is pretty remarkable. So,
Next study, this is the Journal of Trauma in 2003. So this is even farther back that was looking at this. Red blood cell transfusions impact on the length of stay, and you were mentioning that, Hasib. This was a post hoc analysis from a prospective multi-center observational cohort study. And this had, as you were saying, the other types of outcomes looking at ventilator time, ICU length of stay, hospital length of stay, and we see that dose-dependent response here with 0, 1 to 2 units, 3 to 4 units, 5 to 6 units, and greater than 6 units. And once again, I think it's also important to point out that these studies were risk adjusted. So they're taking all the variables into consideration to show just what is the impact of those red blood cell transfusions.
I'm glad you mentioned that, because
Yeah.
I think that's what everybody always says, is when you say, oh, well, they got this much blood and they had these complications, they say, well, they're sicker patients. I mean, and I think and if you just take raw data, they're right. You can't prove it, but a lot of the data that was especially what we made our recommendations based on, they're taking out all the variables and matching these patients, and then using red blood cells as your barometer. That's what you're using. That's your test. And so that's a very important point you make, because almost everyone will give you that first knee-jerk reaction is, oh, well, they're sicker patients because they've had more blood.
You know, we've shown you 3 studies here, and these are kind of the tip of the iceberg. There's been many other studies looking at blood cell transfusions and the risks associated with them. As we saw, this one goes back to 2003, but probably more. A lot of these studies have been showing up in the last 5 years. We also know that in the medical literature, it, for some reason, takes us as physicians 5 to 10 years before we start putting things into play. Once we see that they're really efficacious in the literature, there's always a lag time before we see it appearing in clinical practice. So let me ask you guys, what are you seeing in your practices? And what are you seeing when you go to national meetings? So when you go to surgery meetings or you go to hospitalist meetings, is this being discussed? Do we see large healthcare organizations like the St. Louis Health System embracing this and trying to put this information to use?
Yeah, I think the big challenge is a culture change. That's really what we're talking about. And as a hospitalist, I see this in our national hospitalist meetings, the SHM. We do have some topics that discuss this. We have Journal of Hospital Medicine actually recently had an article about red blood cell transfusion and immune modulation and things that we've really been kind of learning more and more about with new research. So I think it's a culture change, and to change behavior is really hard, especially really smart professionals who have quite a bit of experience, and to come back and kind of challenge what we've already been trained and felt comfortable doing is difficult to do. And so we recognize that. But now, once this data comes through and we start trying to think about it and question it and implement some strategies to how to improve patient outcomes, I think that's where we are. But yeah, I think there's an active discussion going on.
Interesting. I think a lot of our data, if you look back even into the early 90s, there's a lot of data in the trauma literature as far as blood transfusion. And that's where a lot of it started, the surgical ICU trauma trained physicians. As you saw this evolution from operative treatment of solid organ injuries to non-operative treatment, well then you saw this, well, how much blood do we need to give them? And what are our outcomes? And so a lot of this literature, a lot of the initial data actually comes from the trauma literature. We were practicing it back in 96, 97 when I was in general surgery training. So I think it's interesting how long it's taken to bring it to really a national multi-specialty kind of head,
The next slide really gets to the heart of what Dr. Ahmed Hasib was talking to us about, is the true cost of blood. When I transfuse, a lot of times I think, well, I figure this bag of blood probably is a couple $100, a cost to the hospital or cost to the patient. But really there's a lot of background that goes into it. So product acquisition, the hospital blood bank supply management, the pre-transfusion processes, the patient blood testing processes, the transfusion-specific consent, that takes time just to get consent on a patient. And just to point out, physicians haven't historically done a good job of making sure we consent patients for blood transfusions. It is a procedure. The component delivery, the administering and the monitoring transfusions, the managing acute transfusion reactions and hemovigilance, so just the nurse's time of making sure is that patient going to have a reaction. The blood transfusion logistics, getting it up to the floor. The direct overhead, such as the blood bank staff, the overhead costs, at the blood bank, the lab, and nursing, the pathologist costs, meeting attendance by staff. All these people have to stay accredited in giving blood. And then the indirect overhead. We got the equipment, the utilities, non-professional personnel, the property and buildings, and laundry even, and housekeeping. All of that's affected and goes into this true cost of blood. Any guesstimates about what this whole thing costs?
Just the true costs? We're probably, because there's going to be other costs related to this as well. But we're talking hundreds, or on an annual basis.
Yeah, per unit, just for giving
I'd probably say hundreds of thousands of dollars.
For one unit though.
For one unit.
Oh, for just per unit?
Yeah.
I don't know.
I think I've seen it estimated in $1,000 or $2,000
Yeah.
for a unit for this true cost. Well, go ahead.
Yeah, I mean, there's another study in here that kind of talked about, plus the adverse reactions that have, and you can really count up the cost of hundreds of thousands of dollars when they count the length of stay and the amount of adverse reactions and the treatment time that takes place with that as well. But,
From the clinician standpoint, we don't as much think about the money as we think about the true cost to the patient.
right.
Yeah, what's that going to mean to them?
But I guess as a hospitalist, I'm kind of constantly talking about cost efficiency, patient outcomes, and how do I provide care to this patient at the lowest cost possible. So I think, and that's what makes me really excited about, going back to your initial question really is, and that's what's exciting about all this, is how do we really save costs? And now we're learning that transfusions are actually costing quite a bit of money to the system and to national health care.
And that's, the key word nowadays is value.
Mhm.
So we want something that's high quality at the lowest cost.
Right.
So, good. The next slide we've got here is, I think, vastly, it tells us a story. It's vastly important. This variation in transfusion practices. So this was two different studies, one that was in anesthesiology in '98, the other the American Journal of Medical Quality in 2009. So almost a 10-year gap here, but really little's changed. So we see these two studies have multiple institutions in the study. The first one up to 24 institutions, the other one 145 institutions. And this is looking at the percent of patients that were receiving transfusion during that hospitalization. And we see on these, the first study, 27 to a 92% a scatter plot of whether a patient gets transfusion or not. And in the other study, 8 up to even 82% who get transfusion. Thoughts on this variation? Where does that come from? Why are we seeing that much variation between the institutions?
Well, it's a tough answer. I think it a lot depends on location and what your training for that area has been. I think that we all become very comfortable with what we're taught and how we apply it. And I think that the variation kind of depends on where people were in their world as far as education goes when they came out. And not much changes. I mean, you get comfortable with what you've done, and then you don't change that if it seems to be working for you. Now, I think that where we fall off is that we, in the immediate term, particularly somebody that's anemic that feels fatigued. I mean, people give them some blood and say, "See, I made them better." Well, they don't go home with them, and they don't go back to their next hospitalization with them a lot of times, and so they don't know what the long-term effect of their treatments end up being. So there's no impetus to change their pattern, even though they can read, but they're not seeing it directly, and I think that's so. You can put a lot of data in front of a lot of smart people, but if they can't see the implication, then it's very difficult for them to make any change.
I think the other component is patient education. I think on a national level, I think we all kind of have to educate ourselves, educate the patients and the families about these risks of transfusion, because I've seen patients who will come in expecting a transfusion and they think that red blood cell is really going to make their outcomes better, and so that brings a lot of difficulty in that patient-physician dynamic, because if you have a physician who wants to practice conservative strategies and does not want to give that packed red blood cell and provides evidence, well, the patient at the same time and the family at the same time has to be accepting of that, and so I think that there's a lot of education that has to be done. So I think there's a physician component to it, and then there's also a patient-family component to it as well. So it's a big challenge that we have out of us.
Excellent. Looking at our own data, so this is looking at the 2011, what we saw in the St. Luke's health system with transfusions. And this is looking across multiple hospitals in our health system. And it doesn't help in terms of comparing one hospital to another, but what it does help for us to see is the magnitude of what we're dealing with. At St. Luke's Hospital on the Plaza, 6,461 transfusions of red blood cells in 2011. Now, that's a very common procedure. even at some of our smaller hospitals and our critical access hospitals, Western Missouri, Hedrick Medical Center, we're seeing 200 to 300 a year. That's at least one transfusion a day out there. So it does help us understand that this is not a small part of what we do in medicine. It's something that we really need to get a handle on. And if there is literature that shows that we need to make some changes in how we as physicians treat our patients, it's significant enough, and we need to get on the stick and do it.
And that's quite impressive. I mean, like Dr. Davis had mentioned, some folks kind of talk about blood transfusion as a transplant or as another organ transplant, or because and it is a procedure. I mean, if you stand back and think about it, we're actually infusing blood products from somebody else from the community into a patient's body, and so sometimes I think we lose sight of how significant that is. So these are pretty impressive numbers.
Well, and interestingly, if you'll notice, we're focusing on red blood cells,
Right.
but 3,600 plus, almost 3,700 plus units of plasma, which is probably, and in a lot of cases has been shown to be even more impactful,
Mm-hmm.
I guess, on a patient's outcome, a patient's care curve. I mean, their length of stay, their complications, actually more complications been associated with plasma itself, if I'm
Right.
not mistaken,
Yeah.
than it has with red blood cells.
And there's a lot of literature on inappropriate use of plasma. And we're finding out that to change an INR from, I'll just make one point about plasma, is to change an INR from 1.7 to 1.3, for example, takes a lot more plasma compared to changing an INR from 5 to 2 or something like that. So there's, you're going to use a lot more blood products to move that. And there's always debate as to an INR of 1.7, 1.8, are they really a bleeding risk? And so there's a lot of debate about that out there as well.
And that's a lot of times driven by surgeons, fortunately or unfortunately. And seeing an INR of 1 makes a surgeon significantly more comfortable going to the operating room. I can tell you from my experience, because we do transplants on all these cats that have Coumadin, and they don't have to be 1. I promise you.
Yeah, and you used to get the same thing, trolley, taco. I mean, this is all published with
Right.
FFPs as well. So anyway.
Excellent. We're moving on to the next figure. That this came from Facts and Figures 2006, Healthcare Costs and Utilization Project, February of 2011. It was published, and it's looking at this issue about different procedures that we do in the hospital, in medicine, and what has happened over a 10-year period from 97 to 2006. So going down the list, starting at the bottom, episiotomy really fell out of favor, and you see that there's a big drop in that 10-year period of time in episiotomies. Prophylactic vaccinations, well, you'd hope that we'd be getting better at our vaccinations, and that's risen by 67%. Cardiac caths, one of the most common things we do, kind of leveled out during that 10-year period. Only about 14% growth in that 10-year period. But look at blood transfusions. In that 10-year period, it's increased 117%. What are the factors that allow that increase? Blood being more readily available. The number of patients coming through the hospital system probably has increased in that 10-year period of time. But we are the gatekeepers of care when it comes to what patients get. We make the decision. And so there's something that's inside us that believes these patients need more blood than what we used to believe. So while all this literature is going one way, it looks like our practice is going the other way.
Mm-hmm.
Well, I wonder if that has, some of that is impacted, granted at the end, with outpatient use and the use of EPO and what it's paid for. Medicare quit paying for EPO in a lot of these chronically anemic patients, particularly renal failure patients, when their hemoglobin was, I think, 10 is the cut. They used to be able to do it at a little bit higher rate so that they could maintain. And if you talk to a lot of the nephrologists, they're like, well, I can't use EPO anymore, but I've got to give these people blood because they're chronically using it on dialysis. So I think we actually saw a spike back up. We saw a kind of a trend down and then a spike back up.
Interesting. And then we see our annual red blood cell utilization at St. Luke's Hospital. We're tracking how many units we've given each year, and a couple things on this graph. So this is just at the hospital, not the whole health system, but I think it's got some instruction here for us. For one thing, back between 2000 and 2006, we had a bone marrow transplant program, and bone marrow transplant programs often use a lot of blood products. And so we did see a decrease from 11.3 down to 10.3 in that 5 or 6 year period. Kind of like what Hasib was saying, at one point the St. Luke's Health System did have a very strong blood utilization program going on here, and you did see some decrease. The bone marrow transplant program ended here in 2006. We see a big decrease there. Then we start seeing that there's even more decrease from 2008 to down to 2010, maybe a bit of a blip back up in 2011. And I think that's about the same time that you came on, isn't it, Hasib, around in that point?
Yeah, that's exactly right. And I think when we stand back and kind of look at this bar graph, it's for me, it's kind of reassuring or kind of exciting to see the downward trend, you know. And so it just tells me that at least at the plaza, that the culture is changing. People are thinking twice before transfusing, and we're using less and less red blood cells. What'll be really interesting is as our aging population continues and our census starts to grow, what these numbers will do in the next 5 years.
Mm-hmm. One of the things that I think is valuable is look at this next slide from 2008, because it probably really hasn't changed since 2008. And it has to do with whether we as physicians are giving the appropriate indication for our transfusions when we transfuse. So the question on this chart review from 2008 was, what are the indications for the transfusions at St. Luke's Hospital in the Plaza? They looked at all blood products here, and they looked at whether there were transfusions, the physician gave an indication, or whether there were no symptoms that were indicated and a transfusion was given. So you can see 52% of all the transfusions, we physicians didn't have any documentation where we put in the chart why we were given the transfusion or why it was appropriate. Comments?
Yeah. I mean, documentation is so important. I mean, communication is so important. A lot of times it's hard to assess when we do studies like this that just because they didn't document it, were they still thinking about the indications, or were they still investigating about it? I don't know. But a lot of times we have orders that came through on the green sheets to transfuse blood, but there was no real indication to transfuse that patient. So for us, what we've done is kind of gone back to the drawing board and went on an evidence-based approach and made a blood component order set to kind of facilitate and kind of incite a conversation to figure out what is the indication to have a blood transfusion.
And I think that's the point. I think that's the point of all this. That's the point of this
Right.
order sheet is before you write transfuse, you ought to think of why you're doing it. I mean, just like if you're going to put a central line in someone. I mean, why are you putting a central line in? I mean, anytime you intervene on a patient, and blood transfusion should be considered that, you should have a reason for doing that. You should have an expected outcome for it. And I think that blood transfusion has kind of hit a lot of people as just, well, it's maintenance fluid, kind of, you know, we'll just put it on. And the whole purpose of this is have a reason before you treat them with something that's potentially risky as blood.
Right. So asking that question, why are we doing what we're doing? I mean, if the patient's bleeding, obviously there's no question. But in those stable patients where thought process has to happen, and that's where we need to work on.
Well, let me let our viewers know what has happened over the last 6 months or so within the St. Luke's Health System regarding blood utilization management. Because of all this, because of the literature we've gone through, the Blood Utilization Management Committee said one of the things we need to do is really require that physicians think about and provide an indication of why this patient needs transfusion. And we have a list of appropriate indications as well that we know that there's times that it's very appropriate for the patient to be transfused. So the Blood Utilization Management Committee said one of the things we believe is the physicians ought to be expected every time to give us one of those indications. And in doing so, we have an order set that has those indications on it. So when a physician wants to give a transfusion, we have an order set that demonstrates exactly what those indications should be and is easy for the physician to pull out and check one of the indications and put in the blood component order set. The problem is that this was being used very seldomly in our health system. So the Blood Utilization Management Committee recommended to the System Physician Leadership Group, that's the governing body of all the physicians in our health system, that blood component order set should be a required document for anybody who receives a transfusion in the St. Luke's Health System. We spent 6 months or so talking to the med exec committees at each one of the health system hospitals, discussing this with them, talking about what are the appropriate indications, what are the concerns that might be for physicians on being expected to complete this. And they all pretty unanimously agreed, really without any dissent, that this is an important thing for our health system physicians to begin to do. Therefore, the Blood Utilization Management Committee put together a guideline. The guidelines specifies that for physicians to get a transfusion, they should be expected to do this. We're going to look at a couple slides that talks about the indications, the exclusion criteria in this guideline and for this order set. Particularly here we have restricting blood transfusion by mandatory utilization of the St. Louis order set, St. Louis Care order set, and exclusion criteria, emergent trauma, emergent operating room, and neonatal or pediatric patients. I know one of the things that we've had questions about is if I'm a surgeon and my patient's bleeding out, am I going to expect it to fill out this blood component order set? Similarly, we've had in our discussions GI physicians who said, when my patient is coming in with a GI bleed and is bleeding out, has massive blood loss, am I going to be expected to complete this order set? Gentlemen, what does a physician in that case do?
Yeah, I mean, before I answer that, let me just preface by saying that the whole concept of this whole thing is really quite simple. The bottom line is, how do we improve patient outcomes, and how do we provide evidence-based care? That's the bottom line. So to answer that question, and I've tried to be as vocal as I can and let everybody know that in those situations, and we all understand, we're not trying to make the practice of healthcare delivery any more challenging than it already is. Rule number one, as we've all been taught, is save the patient. And so in emergent trauma, emergent cases in the OR, bleeding, OB-GYN bleeds, or any type of active bleeding, unstable patients, they're going to get their blood. The order set does not have to be filled out, and that's why it's an exclusion criteria. No one's going to hold them accountable to fill that form out right that minute, have that fax down, and then get the blood product. That just
So they'll still be able to pick up the phone, call the blood bank, say I have an unstable patient, massive bleed, I need blood now.
Right.
Okay. Right. I mean, I think that in my world, I mean, we get into those situations more often than we care to, but it will remain seamless in the operating room in trauma. I think that the expectation will be is in a later time an indication can be sought, but I think in when we initiate this process, those people that are in dire straits that need blood will immediately have blood available to them.
Absolutely.
And the same process that has always been available, make a phone call, get the blood.
Yeah.
I think that what we actually want to happen a bit more often probably is a massive transfusion protocol initiation. I mean, if you're expecting 4 or 5 units of blood immediately, initiate the protocol. Then if anybody has it available to them, I mean, look it up. It does all the thinking for you of when you should be able to give, when do you need to add FFP, and when do you need to add platelets, and when you need to add cryo, etc. So,
and that's a simple phone call directly to the blood bank.
Very simple.
One-stop shopping.
Yeah.
Right. Inclusion criteria, we have patients with a hemoglobin less than 7, blood pressure less than 80, heart rate greater than 110, not corrected by adequate volume replacement, evidence of end organ ischemia, not recommended for fatigue. We've got symptomatic with a hemoglobin less than or equal to 8, and those with pre-existing cardiovascular disease. We've got in patients with acute coronary syndrome with a hemoglobin less than or equal to 8, and a patient has any two of the following: angina, new EKGs changes, or abnormal enzymes. Then we have acute massive blood loss, which we just talked about. That would be an inclusion criteria for transfusion, not necessarily for the order set, but that's for a transfusion. And then non-elective pre-surgery hemoglobin less than or equal to 7 with anticipated blood loss of greater than or equal to 750. Did we miss any that are actually on this
Well,
order set per
I
se?
think we actually, we were somewhat nicer. I think the order set actually, if they are less than 7, even if they're asymptomatic, the
Okay.
data would support
Great.
that it's acceptable. The data is very hard at 6. Anything less than 6, transfusing that can potentially be life-saving. Between 6 and 7 is a bit of a gray zone. The data is not supportive at all of just, just kind of throwing it on people. Not at the level it is at 6. At 7, it's got a potential effect, and we thought that it would be reasonable for those patients that had a hemoglobin less than 7, even if they're asymptomatic. If someone felt that their patient needed blood, that they should be able to get it. I think that we're going to require that the doctor actually look at the patient and understand that they're symptomatic if their hemoglobin is less than 8, but above 7. I think that, or 7 or above, because I think that's that period where people go, anything drifts below 8, give them 2 units.
Right.
I mean, that's the reflex. It's been the reflex. Anything below 8, you just give, or if it says 8.9,
Right.
So I think that we didn't want to be so strict and require people below 7 to have overt symptoms. I think that would hurt us
Okay.
from a feedback and adoption standpoint.
And I think the indications are quite comprehensive. I mean, if you
They
look at
actually
it, I
are.
mean, they include a lot of different patient populations, and I think that comes from the blood utilization committee that's multidisciplinary. And I think the point needs to be made that a lot of thought went into it, a lot of teamwork went into it, a lot of champions from multi-specialties came together to make this form. It's not like Dr. Davis and I sat in a closet and made this order set, but it's it's very it was a lot of hard work, and so
It's been vetted to multiple physician groups on the campuses. It's been vetted to the Nurse Practice Council. We've talked to a lot of people about it. The last thing to kind of walk people through is we expect that this will be implemented over the course of the next few months. So starting in 2013, you should be seeing a lot of education before 2013 about this. Your hospitals will be going live in the St. Luke's Health System with this order set requirement as each one comes online fully educated and ready to go. And we're going to let the physicians and the nurses at each of those institutions let us know when that's going to be, when they're ready. It's not going to be a long time, but we do want to make sure everybody is fully on board, well educated on the process. We want the process to flow very easily. We want this to be a team effort. This is not tennis or ping pong. This is more like basketball or football, where you've got a team approach with the physician, the nurse, and the IA who are all together trying to make sure that a patient who needs a transfusion, that we've got the blood component order set there available, we get it filled out, we make sure the appropriate transfusion indication is listed, and then we get the patient the blood as timely as possible. Gentlemen, anything on last words on this process change, on what you want the people out there to know about this?
And again, it's really to improve patient outcomes. And like you said, I think that's a great point. It's a team effort. The nurses, the physicians got to work together in making this happen. At the end of the day, to be honest, if a physician can sign this order set and do it, it's a lot more efficient, and it eliminates any other further questioning. And it'll just make a smoother process. If not, we all understand, and that's where the nurses can step up and help follow through and complete the form. These forms, being an evidence-based facility, we use this to extract data. So it would help us out, because then we can produce some data points and quarterly make reports and share with everybody else throughout the health system and see how we're doing. And again, this form is flexible. We're always open to, I'm just an internist, and we all have our skills, we all have our weaknesses, and no form and everything else is perfect. And so this is a work in progress, and if there's any feedback, let us know. We're willing to work on it.
Yes, multiple cycles of improvement is the St. Luke's Care model. So we have PD, SA, plan, design, study, and act. So any last words? Russ?
I think that in my field, I can follow this fairly easily. Every patient that I've ever given blood falls into these categories. And if we take the time to think about why we're doing it, then your patient will fit into one of these very simple reasons for giving transfusion. And if they don't fit in it, maybe we ought to rethink it. Maybe we ought to rethink what we're doing and why we're doing it. And that's the whole purpose, is we want old and new physicians, we want nurses and the lab techs and the people involved to think before they intervene. And that should be our practice in general, but we've kind of let it lag here, and I think that's important to get across.
Well, thank you very much for taking time, watching this video, learning a little bit more about blood transfusions and our blood component order set, this new initiative from the St. Luke's Health System. I want to thank Dr. Hasib Ahmed for joining us today, and Dr. Russell Davis, thank you very much for taking time to be with us, and be looking for other St. Luke's Care CMEs out in the future. Thank you very much.